Okay, great. And I will share my screen again. Go into presentation mode. Okay, great. Can everybody see the screen, the slides? Okay. So today's agenda, we're going to talk, we'll just each introduce ourselves. We'll talk a little bit about mind-body medicine and playing safer. So there are some updates on how to protect yourself and your partners and playmates from sexually transmitted infections that I wanted to go over, and new data on prevention. So as I said, I am Dr. Amber Hall. I'm a board certified pediatrician. I live in Las Vegas, and I specialize mostly in pediatrics, but I have a background in maternal and child health. I did all my elective rotations in medical school in women's health, so high-risk pregnancy, GYN oncology, pelvic floor reconstructive surgery. So I've always had an interest in women's health, but from a clinical standpoint, I practice pediatrics. I have an interest in more of like an integrative, holistic approach to patient care, because I don't think that we can separate our physical health from our mental health, from our sort of social surroundings and cultural stressors. So I think that we're kind of an entire organism. And so I try to practice medicine with that in mind. I also have an interest in human sexuality and the connection between our minds and bodies and how that manifests in our connections with other people. In my abundant free time, I am an athlete, an aerialist. I do a lot of writing, especially on the topic of human sexuality, and I do a little bit of modeling from time to time when photographers ask me to do that.
Oh, my turn. So I am Dr. Khristina Booth. I'm board certified in family medicine. I'm an osteopathic physician. I am also now the Chief Director of Primary Care at the Veterans Health Administration in the Bronx. I also specialize in women's and LGBTQ health at the Bronx VA as well. So for veterans especially, also do abortion care and some other specialized areas there. I am a mom of 2 kids and a wonderful husband, and I'm a big gamer, big Zelda nerd, and just nerd all around. Love reading. Yeah, and I'm big into informatics and technology and sexual health in all aspects, from the chemical nature of it to advocacy, down to just wellness and happiness with it. That's me.
Lovely. I'm so glad you're here. All right. So I wanted to start with a slide because in osteopathic medical school, we have very much a focus on mind, body, spirit. And you don't have to be a religious person to, believe that there's some sort of spiritual aspect to ourselves. So I want to separate kind of the religion aspect and talk about the elements of sexual health as I see them. And that's what this slide gets at. So our mental health affects our physical health and our sexual performance. So people will often talk about, if they're going through a particular set of life stressors, or, struggling with anxiety, or, guys will sometimes say, oh, I'm just in my head about this thing. And so, I'm struggling with erectile dysfunction. Women often after pregnancy or when they're going through menopause, those types of chemical changes have an effect on our bodies and on our mental health. And so all of these things play in together in terms of our sexual performance, our desire, our libido, our ability to connect with our partner. From the spiritual standpoint, I don't claim to know much about Tantra. We did have someone come and speak a little bit about Tantra at the event that I hosted in May. So I know a little bit about like white Tantra and pink Tantra and red Tantra, but my, very elementary understanding of it is that it focuses more on the spiritual connection between partners. And sometimes that's completely non-sexual, and it can be just like an energy exchange. And oftentimes, in our sexual experiences, we feel very connected with the other person. And, yes, there are hormones and neurotransmitters that play into that. But a lot of people describe it as, feeling very spiritually connected or fulfilled or nourished by the person that they're engaging with. Our bodies, any medical diagnoses that we have obviously have an effect on our overall physical health. So if we're struggling with injury or malignancy or, lack of vaginal lubrication as a result of being postpartum or perimenopausal, all of those things that are going on with our body can have an effect on our confidence, our stamina, and our ability to show up, both for ourselves and for the other person. And, Khristina touched on this too with the advocacy element. There's a lot of societal expectations that play in dramatically to our sexual expectations of ourselves, of other people, sort of constraints that we put on ourselves, the lens through which we view ourselves, whether that's as a mother, as a lover, as a professional. We wear a lot of different hats. And there has historically, and at least in this country, been the building up of taboos and things like that you shouldn't do and you shouldn't say and you shouldn't ask for and you shouldn't think about, that really have a huge impact on people's relationships, and what they're comfortable asking for. And really the apps, I could go on a tirade about them, and I have, and I will in my writing, but technology has sort of created this milieu where these apps monetize the desire for human connection, in a way that I think cheapens human connection, because it's become so easy to scroll through just photos and like looking for the next best thing. It's like shopping on Amazon, but you're doing it with human people. And so all of these things play into our overall sexual health and how we engage with others. I wanted to talk briefly on consent, because I think the statistics at this point are that like 1 in 4 women and 1 in 5 men are victims of sexual assault at some point in their lives. And having a history of sexual assault can have a huge physical and emotional toll on people that can make it difficult to connect with someone, to trust someone. And so on the topic of consent, my take on it is that consent should be freely given. And I tell my adolescent patients this too. I had girls that went off to college this year, and I was like, you can revoke consent from anyone at any time for any reason. And consent should be enthusiastically and freely given. If consent is given under coercion, if someone is begging, if, an individual is feeling as though they have to give in to the other person's sexual advantages in order to avoid uncomfortable conversations, that's considered manipulation, and it's not consent freely given. I would also make the case that one cannot give free enthusiastic consent if they're under the influence of alcohol and substances. So, many people like to have a drink or two, but if someone is inebriated to the point that they can't drive, I would argue that they shouldn't be making decisions about themselves and their bodies. And those things need to be taken into consideration. Minors obviously cannot give consent to adults. The age of consent, obviously things like a 17-year-old with a 20-year-old or a 15-year-old with a 17-year-old, those things come into play, but special consideration for minors. And I'm planning to do a second webinar that specifically addresses how to talk to kids in a developmentally appropriate level about development, human sexuality, consent, all of these things. Overall, if it's not a hell yes, it should be a hell no. So I will turn the floor over to my colleague. Talk to us about orgasm.
Thank you. Yes, orgasm. So I actually did like an interview for a magazine talking about orgasm science and kind of what happens in your body with masturbation and orgasm. And you would be so surprised at the amount of people that really have no idea kind of about their body. They don't really know where anything's located. They don't know how it works. They don't know what makes them tick. And this is especially true in women who often have no idea that they even have two holes down there. Some women still, especially older women, believe that they urinate out of the same hole that their vagina is in. So there's a lot of misinformation that's out there, and just a lot of poor education when it comes just to basic anatomy, not to mention the whole anatomy of sex organs. I included like a few pictures here. One that I think is interesting on the top left, the circle, is the male penis and the clitoris. And you'll see that they're very similar in their anatomical structure, even though we would not think so just from looking at them from the outside. They both develop, excuse me, I have a horrible cough, from the same apparatus. Everybody starts off with the same parts, and then in the womb you separate out into, what is considered male genitalia and female genitalia. And those nerves are both essentially going to those two parts. And then, so you can see they've highlighted the zones on that top left showing similar nerve conduction areas that are located. So just like with the male testes and scrotum, that's going to go along with like the labia majora of a female area. So the clitoris, the head, it's all going to have similar nerve connections and how they're stimulated. So we're a lot more similar than a lot of people think. And the stimulation that we undergo throughout erogenous zones is very similar between men, women, intersex, non-binary. Everybody kind of has a very similar way. How we reach orgasm, though, is slightly different based on our chemicals combining with our anatomy. And excuse me, especially in women, it's a little bit harder to reach orgasm in circumstances due to these chemicals and hormones. You can see on the large picture there, that's showing like all of those different areas and excuse me, what they lead to, which nerve, and kind of how they get some cross signals. So there's multiple ways that like the cervix can be stimulated, and it can go to different nerves and then go up to another nerve into the brain. And so that's how you can get stimulation from different erogenous zones, giving you feelings at different locations. The middle picture is prostate stimulation for a male. And then the far right is just some more anatomy of the clitoris and all of the area, also showing the G-spot. So stimulation from behind the glands is going to help as well. So you can see that there's a lot going on that can lead to stimulation in the brain for an orgasm. And really the education behind this is what's lacking, and something that's very important to sexual health and development, and something that's often not discussed among patient and providers, and something hopefully we can improve as we go. We're just now including the anatomy of the clitoris in Netter's anatomy. I think 2 years ago, it was just included. So that's how far behind we are in medicine on sexual anatomy and development. So you go to the next one. Yeah. Okay, so this is getting a little bit more, more into the chemical nature of an orgasm. You can see on the top picture there, that is kind of the nerve conduction signals of an orgasm happening. On the top left, you have the classic one. So that is where you slowly build, you have an orgasm, and then you come down into refraction. The next one over is kind of like a few quick orgasms in, in succession. So that would be like a woman having an orgasm with multiple contractions happening. C would be having an orgasm, having a slight refractory period, having another one, slight refractory, another one, and then maybe you're able to achieve one more after that. Again, women tend to be able to achieve that a little bit better. Their refractory period is shorter. And then the last one is status orgasmus. It's rare. So it's when an orgasm consistently builds and it's almost like a muscle spasm. So it's not exactly, it's at first it's good and then it's bad. So we don't want that to happen. But the chemistry of this is important because when you orgasm, you do have these different phases that happen. And a lot of those phases are hit by a very fine balance of chemicals happening in your body. And in men and women, this is different. But we can see a lot of the same things in all sexes. You can see that testosterone, progesterone, estrogen, dopamine, adrenaline, those sorts of things help to promote the progression from desire to subjective excitement to orgasm. Whereas, excuse me, you have some things like prolactin and serotonin that will downregulate this. So they can make it harder for you to reach orgasm. And sorry, man, this cough is driving me crazy. We can see this with people that are on SSRIs. So if you're on something like Paxil and you have a selective serotonin reuptake inhibitor, which is an SSRI, that is going to cause an increase in serotonin, which might drive down your sexual drive, or it might decrease the ability to reach orgasm as you, even if you have the libido and you have that sexual excitement, you might not be able to fully reach orgasm just because that serotonin is blocking that process from happening. Similarly, if you're in a state where you're anxious and you're not trusting of the situation, you're going to have other chemicals coming in and decreasing the movement into where you need to be to reach orgasm. So there's a lot of things that come into play. In the background, you can see there's like an MRI. I didn't put the full picture where you could see it, but it shows like where the different areas of the brain light up, and they're studying this. And it's the same areas that are for drug addicts when they take heroin, when they take other drugs. When you reach an orgasm, you're getting that similar dopamine and euphoria feeling. And this can actually help to treat pain. It can help with depression. It can help with so many other things. So this could potentially also be used as treatment options for alternative therapies for other things. So yeah, lots of science behind it. Super interesting. Lots of great books out there. If anyone is interested, would love to go into more detail on this in the future. And so, like I said, excuse me, it's all about getting to the balance. So again, you can see the dopamine, norepi, oxy, adrenaline, they're going to increase that pleasure. So they're going to weigh down the seesaw there. Whereas the serotonin, prolactin, progesterone, cortisol, the stress hormone, those are going to decrease it. And all of these sorts of things have to, the teeter-totter, they have to be in the right balance in order to reach that orgasm. And so one of the things you can do is by working on your mental health when it comes to sexual health, making sure that's in a good place, working on your situation and feeling safe in your sexual activities. And excuse me, there are a lot of great apps and books and meditation and things that can help you slowly like move through those phases. If you're having difficulty getting past the mental blockade for reaching orgasm or enjoying sex on a personal level, a lot of these things are about helping to reorganize those chemicals mentally. And then there's also herbal supplements. We talk a lot about things like black cohosh or soy. Soy increases estrogen. Black cohosh might do the same thing. For men, there's horny goat weed. Like that's a very funny herbal supplement that can help increase testosterone and nitrous oxide. Beetroot also can increase nitrous oxide. Um, so there's a lot of different things you can do to kind of help stimulate this balance and get it to where you need to be. And then along with the mental health and learning about your sexuality and learning about your anatomy, you can kind of bring that all together to get to the best kind of sexual health and wellness that you can, and to achieve like your personal goals as far as what you want to accomplish sexually. So that's the science.
So I think you raised a couple of points that I just wanted to circle back on, because again, from my standpoint, like mind body medicine and an integrative approach is really where I try to come from on these things. And I've been doing some of my CME on integrative approaches to anxiety and depression. And the things that you mentioned, SSRIs, sometimes people are prescribed beta blockers, either for anxiety or for, public speaking, or blood pressure reasons. Yeah. And so I think that in medicine, we do a huge disservice to patients by not really being comfortable having these conversations with them and not really knowing the right questions to ask, because often I feel like patients either won't bring up that they're struggling with their relationships, or their sexual health, or doctors don't know how to facilitate the conversation. And I think a really important question to ask is like, how are the medications that you're taking to handle things that are going on with your body and your mental health? How are those affecting your sexual desire, libido, performance, that ultimately affects your relationship with your partners? And these medications can have powerful effects. And I also learned recently that antihistamines like Zyrtec can reverse the effects of Cialis. So if someone has taken Cialis and has a 4-hour or has a 4-hour erection, one of the first go medications is an antihistamine to reverse the effects of that, which I thought was interesting. But again, it's just it's all connected.
I did want to add to, like, as far as like gender differences go, sometimes like men will have a very strong sex drive and women will not necessarily. Or what we can see is that there's an ebb and flow to women, so that goes along with their cycle. Men, we often say they have a daily sort of ebb and flow of hormones, whereas women have a monthly. And so women can sometimes be very sexually active around their ovulation time. And then they have an increase in prolactin after ovulation, or even after a period of multiple orgasms during a week. And then for the next coming weeks, evolution wise, their body is telling them that they do not need to be sexually active because they want to hold on to that sperm that they've taken in for evolution purposes. And so a lot of times in women, that hormone play will make their libido suddenly just be gone for like 2 weeks, 2-3 weeks. And then suddenly it's back. And then that can change based on if you have PCOS, or if you were just recently pregnant, or, medications and stuff. So I think that is also a big thing you have to understand, especially between the sexes, where your sexual desire might not sync up, but it might just be because of hormones and not necessarily because of your attraction to one another.
Absolutely. And I hear this pretty commonly from women in the postpartum period. Your body has just gone through some of the most dramatic changes that you will experience in life. And the drop off in the hormone levels after you have a baby basically throws the body into essentially perimenopause. And women can struggle with decreased libido, lack of desire, on top of the fact that they're breastfeeding and, just completely touched out from, having a baby and losing sleep and all of these things. And so it can be really quite distressing for some couples. So I think it's, again, going back to the mind body medicine thing, it's important for us to remind patients to keep the long game in mind. Like, this is not only are there ebbs and flows on a monthly or a daily basis, there are also chapters in a long-term sexually exclusive monogamous relationship where things are going to kind of ebb and flow. So just important things to keep in mind. So on the topic of bodily autonomy and how to talk to your doctor about this stuff, I think it's great that there are more doctors who are becoming more open to having these conversations with patients, but there still is a lot to be desired in terms of continuing medical education. And I have made efforts to offer continuing medical education for the kinds of things that we're talking about tonight, but I have gotten shut down because we don't talk about sex in the ivory tower of medicine. But that just means that we have to advocate for ourselves. And there are a number of different resources that are out there and commercially available. Physicians' offices, like finding someone like Khristina or like me who is open-minded about talking about issues related to LGBTQ health, to women's sexual health and pleasure, to non-monogamous relationships and sensitivity to kink. I've put a few organizations on here. Outcare Health, I actually did some of their continuing medical education this year as well. They have great resources, and on their website, you can search for physicians who are friendly and sensitive to LGBTQ issues, including gender affirming care. The catprofessionals.org is a national database of kink and polyamory aware professionals, not just physicians, but also licensed clinical social workers and therapists and counselors and lawyers, like anyone who is sensitive to the needs of sort of found families and non-traditional family roles. Planned Parenthood has been doing great work and are still out there on the front lines, making sure that we have access to things like pregnancy prevention and treatment and screening for STIs. The local health department here is where I go and get my own vaccines. So it's easy to look up. You can make a vaccine appointment and go in. They also offer screening and treatment for STIs, and some of them even offer PrEP as well. HelloWisp.com is a commercial company that offers confidential screening and testing for sexually transmitted infections. And GetCleared.com is the industry standard. Like, that's where professional porn stars and sex workers go and get their screening, because the industry standard is actually a lot more substantial than generally what people are getting from their physicians' offices. So on the topic of industry standard STI screening, this is a complete panel that basically porn stars and professional sex workers go for. So there are two different screenings for HIV. The first one, the nucleic acid testing, this will give results quicker. So the detect actual like proteins and viral particles that'll show up within like 10 to 33 days, whereas HIV antigen and antibody testing, it takes much longer for the body to produce antibodies. So someone can test negative for HIV antibodies when in fact their body is harboring the virus. Hepatitis C is sexually transmitted and also bloodborne. So people who use injection drugs are more susceptible to hepatitis C. There is not a vaccine for hep C. And hepatitis B is also sexually transmitted. So hepatitis A can be too, from fecal oral route, but hepatitis B and hepatitis A both have vaccines available. You can get them as an adult, and I would recommend doing that. Syphilis has been on like a huge upward trajectory since everybody came out of COVID. It's actually a big problem. It's caused by a spirochete called the Treponema pallidum, and I have an entire slide on that talks about treatment and transmission. Trichomonas vaginalis is also a bacterial infection that you can get in the vaginal canal or in the anal orifice, the rectum. Gonorrhea, chlamydia, we test urine, but really people who are performing oral sex without barrier, even if you are using barriers during oral sex, which not very many people do, should be getting throat swabs. Many doctors order urine testing and blood testing for a complete STI panel, but you actually can transmit gonorrhea, chlamydia, syphilis orally to genitally or orally to orally. So anyone who's performing oral sex should have oral swabs. Anybody who's receiving anal sex should be getting rectal swabs as well. Mycoplasma genitalium was recently added to industry standard STI screening because there was an outbreak amongst performers that actually shut down production. So we'll take these one by one. The human immunodeficiency virus, back in the 80s, this was basically a death sentence. Now it's become more of a chronic disease that's managed with medication, and people who have the virus can actually get to the point where they have undetectable viral loads and are no longer contagious. So it's transmitted through blood and bodily fluids. It's most easily transmitted through the rectal mucosa. So anyone who is receiving anal and rectal sex is going to be more likely, and it's possible to transmit it orally, but it's much more likely for scientific reasons that are beyond the scope of this talk. It's much more likely that it's going to be transmitted rectally. Testing, I already talked about the nucleic acid and antibody testing. So if you go to the health department or a clinic and you suspect that you may have been exposed to HIV, you can take post-exposure prophylaxis within 72 hours of a known exposure, and it decreases the likelihood that you will seroconvert into HIV positive status. I already mentioned about the undetectable viral load. I've gotten questions about PrEP recently, and it surprised me that there's still a lack of knowledge and understanding amongst physicians about PrEP. So PrEP is pre-exposure prophylaxis. Folks who either consider themselves high risk or are high risk for various reasons can go on PrEP, and it's a medication that's taken daily, and it prevents the transmission of HIV. So there are certain tests that you have to undergo if you're going to go on PrEP, and you have to have your liver enzymes checked on a regular basis. You have to have your kidneys checked on a regular basis. Obviously, you have to be screened for other STIs on a regular basis. But PrEP is a really good option for folks who are at high risk of contracting HIV. For folks who are diagnosed and thank you. So there is a multi-drug regimen that HIV positive people take for treatment that uses a variety of different mechanisms and obviously under physician supervision, but can bring them to the point where they live long, healthy, normal lives, can have relationships with people, can not transmit the virus to their partners because they have undetectable viral loads and their partners on PrEP. So it really has become a chronic illness, yet it still continues to carry a lot of stigma. So hepatitis B and C, we talked a little bit about. The word hepatitis means inflammation of the liver, and there are these 3 different viruses that cause that inflammation. Over time, someone who, especially with hepatitis B and C, these viruses predispose to liver disease, cirrhosis. A and B can cause acute hepatitis. C is more of like a long-term chronic thing. But especially in people who are habitual drinkers, hepatitis can definitely lead to a shorter life expectancy. And the treatment for hepatitis C is, I think, interferon A. It's not pleasant, but folks should be getting screened annually for Hep C more frequently if they're at risk or involved with people injecting drugs. Herpes simplex virus. This is a whole can of worms. So there's a lot on the screen, and there's a lot of still stigma and misunderstanding amongst the public surrounding HSV. So I'm going to spend a little time on this. So either, like, historically, people thought of HIV-1 being, or HSV-1 being oral herpes and HSV-2 being genital herpes. In the world where everybody is performing oral, receiving oral, in sexually active adults, HSV-1 can be either oral or genital, and one isn't any better or worse than the other. this virus is very common. Up to 30% of adolescents have herpes simplex infections. And I actually missed a question in the Q Bank on this like 2 nights ago because I thought that the prevalence was lower, but it's not. Especially folks who are compromised can get esophageal infection of HSV that can be pretty uncomfortable and difficult to treat. And this virus is transmitted from skin to skin or mucosal contact. So even if you're religiously using condoms, there is still the risk of transmitting this virus either orally to genitally, or if there are inactive lesions in areas that can't be seen and aren't covered by condoms, you can come into contact. And this is the reason why it's so prevalent. Viral shedding can happen even in the absence of active lesions or symptoms. And having HSV antibodies does not mean that a person can transmit. So you saw my industry standard list of tests, and you notice that HSV was not on that. And a lot of times the public will be like, well, my doctor didn't test me for HSV. The reason for that is because it's so prevalent. Many people have and are, producing antibodies against HSV 1 or 2 or both, but they've never had an active outbreak, or they had like one 40 years ago when they were a kid and never had another outbreak. And people who have or test positive for HSV antibodies often will go into this sort of mental crisis, like, oh my God, my sex life is over and I'm, damaged goods, and, really like go into a meltdown over this diagnosis, when it doesn't mean that they're ever going to have an active outbreak or that they're ever going to be transmissible to their partners. The gold standard for diagnosis for HSV is an ELISA, from a culture from an active lesion. So if a patient comes in, particular lesions for the first time, the gold standard for diagnosis is culture that, run an ELISA, and get the diagnosis. But sometimes people don't come in when they have active lesions, either because they're freaking out or they're embarrassed or whatever. So, the history from a clinical standpoint, the history is enough for me to be suspicious and even potentially start suppressive therapy. On that note, suppressive therapy, patients can take either acyclovir, which is dosed multiple times a day, or valacyclovir, which is a once daily dosing, and that decreases the frequency and severity of outbreaks. It also will decrease the likelihood of transmission. So if someone is on Valtrex daily, they're going to be less likely to have outbreaks on a frequent basis, which means they're going to be less likely to transmit to their partners over time. It's also really important for pregnant people to be on acyclovir or valacyclovir, because herpes simplex virus can be neurologically devastating to newborns. And I have seen it happen where an infant was born to a woman who was unaware that she had HSV, and we ended up having a very, very sick baby in the NICU. So important to reveal to your doctors, obviously, if you have this and are pregnant or will become pregnant. So on the topic of disclosure, I'm a big proponent of regular STI testing and just becoming comfortable with having the conversation about sexually transmitted infections with people that you're choosing to share your body with. So disclosure of HSV is one of those things that I advocate without reservation. And one of the reasons for that, or another reason for that, is that people have been sued for giving HSV to other people without disclosing their status. And people have won hundreds of thousands of dollars in these lawsuits. So if you have HSV, just get comfortable talking about it with your partners, get comfortable asking questions, get on suppressive therapy, and disclose. And if someone makes the decision not to engage you because you have that history, then there's millions of other people out there that potentially want to be in your life. Human papillomavirus is another that's very common, and the knowledge base about it in the general population is pretty low. There are about 150 different strains of human papillomavirus, and about 40 of them are specific to the genital region. Transmission, again, is skin-to-skin contact. There are 2 strains of human papillomavirus, 16 and 18, that are cause like 90% of cancers of the cervix, the penis, the anus, and head and neck cancers. So these are all places, again, because of the ubiquity of oral sex, you can get these viruses in your throat and they can cause cancers in all of these places. Genital warts, I think the two most common of that are 6 and 11, if I remember correctly. But most people clear human papillomavirus. The overwhelming majority of sexually active adults will be exposed to HPV at some point in their lives, and many of them have it and never know. And the body just clears the infection and they never know about it. We don't even test for HPV in guys. Women and people who have cervixes should be going to get a pap smear every year, because that Papa-Nicolau test of the cervix detects human papillomavirus and can tell us if we're at increased risk of developing cervical cancer. But for guys, they can have it, and unless you see warts, you would never know. The Gardasil vaccine has done wonders for decreasing the incidence of human papillomavirus in the general population. So before the vaccine, there were 355,000 approximately new cases per year of HPV-related cancers. Now, we're not even talking about genital warts, cancers. After the vaccine, that number dropped by 90%. So between 2011 and 2016, there were less than 35,000 cases of HPV-related cancers. So I am a big proponent of educating the public on the effectiveness and the safety of the HPV vaccine. I am a pediatrician, and the recommendations from the CDC are to start vaccinating as young as 9. Unfortunately, children fall victim to sexual assault at young ages. So when I was training in Baltimore, we started vaccinating kids as young as 9. The really getting kids started between like 11 and 12 years old is more my clinical approach at this point. But if the vaccine series is started before 15 years of age, it's a 2-shot series. If it started after 16 years of age, it's a 3-shot series over the course of 6 months. Insurance will cover this for kids who are uninsured through the Vaccines for Children program. Many insurance policies will cover it. But even if it doesn't, knowing that you have like that the vaccine has decreased the prevalence of HPV by 90%, I think that it's worth every penny of that for $350 per dose to get vaccinated against HPV. Now, there have been recent updates in the recommendations on who should get the HPV vaccine, and I get this question a lot. So recently, the age was increased from 26 to 45 on who's recommended to get the HPV vaccine. And the reason for the old recommendations is that, you know, most adults will have been exposed to HPV by the time they hit 26, 40 years old. But because the Gardasil vaccine covers 9 different strains of the most high risk strains of HPV, if one has been exposed to, you know, type 45 earlier in life, you could still be susceptible to infection by 16, 18, 6, and 11. So just because you've been exposed to some form of HPV by the time that you're 30 years old doesn't mean that you couldn't still come into contact with a high risk strain. So my recommendation when people ask me is, if you're an adult, get it. I even recommend it for people who are over 45 if they're sexually active, because if you go through a divorce and you're getting back out into the world and there's a potential that you could be exposed to a high risk form of HPV, that having that vaccination on board to prevent things that you don't want to have, like head and neck cancer and genital warts, to me, it's a no-brainer. Gonorrhea and chlamydia, these are both bacterial infections, again, that can be harbored in the vagina, the rectum, the throat, and even the eyes. I have seen ocular chlamydia detected through a urine test, a vaginal or urethral swab, swabs of the throat for people who engage in oral sex, and rectal swabs for anyone who receives anal penetration. These bacteria can be spread by toys, so make sure that you are washing your toys thoroughly with soap and water between people who they are used on. For the doctors in the room, the treatment for these things are, just as a reminder, chlamydia is treated with 1 gram of azithromycin orally. Gonorrhea is treated with 500 milligrams of intramuscular ceftriaxone. So it's just shot. It hurts like stink, but it'll make your gonorrhea go away. Co-infection can happen. So often with patients, if we know that they're infected with chlamydia, we'll go ahead and treat them for gonorrhea too. And partners should be notified and treated as well, because otherwise you're just going to get into the cycle of passing it back and forth to one another.
I did want to add that recently the chlamydia is now treated with doxy as well in areas where there's resistance. So that's one of the weird things, because we used to just give a shot and be like, go, but now we have to give the oral meds, like watch them take it. And then they have to continue and go pick it up at the pharmacy. And that's kind of decreased the rates of treatment, because it used to just be a quick shot, but now there's pills. So.
Yeah, definitely. And antibiotic resistant gonorrhea is definitely a thing. And I'm going to talk a little bit about that when I get into doxypep here in a couple minutes. So syphilis, this is a sneaky one. It's a bacterial infection that can be latent in the body. So some people can have syphilis and may not even realize it. If it is symptomatic, it can just look like a painless ulcer, or chancre is the word that we learned in medical school and recognize on our board exams. But it can also present as painful lesions. But some patients, again, are completely asymptomatic, which again, routine screening. Left unrecognized and untreated, syphilis can cause cardiac damage. It can cause nervous system damage. It can cause, vision impairment. It can cause blindness. It can cause meningitis. Just a host of really bad clinical manifestations. In pregnant people who have syphilis, it can be transmitted to the fetus and can cause birth defects in those kids. And the rates of congenital syphilis have also gone like off the charts between 2019 and 2021, to the point where there's actually a shortage of Bicil in LA. Testing for syphilis is there are a few different tests, and I'm not going to prepare the doctors for board exams, but there are blood tests and quantitative titers that can be drawn, and a patient can continue to test positive for syphilis even after active infection had treated. So the test will stay positive for a while. Just as a reminder, again, for the doctors in the room, it's parenteral, so not through oral medications. It has to be given intramuscularly, or some patients require IV treatment with Bicil in LA, and there's been a national shortage that the CDC is keeping an eye on that medication, and partners, again, to be notified and treated. Trichomonas vaginalis is a bacterial infection, again, of the vaginal or rectal cavity. Can be detected with urine tests or swabs, can also be spread with toys, with metronidazole, and partners should be notified. There are a few other infections that can happen in the reproductive system that aren't necessarily sexually transmitted. Urinary tract infection we commonly treat that with Bactrim, but it's important to keep in mind when you are playing that you never go back to front. So any bacteria that gets sort of like ground into the area of the urethra, which is very near the clitoris, can get up into the urinary tract and cause a urinary tract infection. Bacterial vaginosis is not always sexually transmitted. It can come about as a result of a change in the pH of the vaginal flora that causes an overgrowth of either Gardnerella vaginalis or Prevotella, and is treated with metronidazole. Yeast infections, which are treated for fluconazole, those can also be antibiotic related. So if I'm treating a patient for a urinary tract infection with antibiotics, I almost always, if they're an adolescent or adult, I'll also treat them with fluconazole, because I'm going to wipe out the good bacteria in the vaginal canal and give them a yeast infection. Mycoplasma genitalium and ureaplasma, again, can be sexually transmitted and can be tested for with a vaginal swab. I don't know that it's tested for with urine at this point, but it can be detected with a urethral or a vaginal swab.
Molluscum contagiosum is it's again a virus that is transmitted skin to skin. It when it pops up in adults, I commonly see it in children, and it's not sexually transmitted. It's just a virus that gets on the skin. They pick it up at daycare, and they have these little kind of like flesh colored bumps that, you know, get itchy, and they scratch them open, and then it spreads. But it is very contagious, and often when we see it in adults, it's in the genital region, because that's when you have skin to skin contact with other people. So doxypep, I'm really excited about this. There was a study out of UC San Francisco that was done. I think they launched it in like 2020 or 2021. They cut it off early in 2022 because the data was so overwhelmingly convincing. And the study population was gay and bisexual men and trans women that were given 200 milligrams of doxycycline within 24 hours, no later than 72 hours after condomless oral, anal, or vaginal sex. This one-time dose of 200 milligrams of doxycycline reduced the risk of gonorrhea by 55 to 60% and decreased the chances of developing chlamydia and syphilis by 80% or more. So this is the reason that they called the study off early. It's just the data was so overwhelmingly convincing that it would have been unethical to continue not treating the patients in the control arm of the study. Unfortunately, there's no useful data to date in cis women. There was a single study that was done, I want to say it was in Kenya, but it was a study done in cis women that didn't show efficacy of doxycycline when taken after vaginal sex or oral sex. But when they went back and looked at the data, the study population wasn't adherent to actually taking the medication. So it's not enough data to make recommendations in cis women. Currently, doxypep is recommended for men who have sex with men and trans women who have been diagnosed with a sexually transmitted infection within the last 12 months because they're considered higher risk. But from a clinical standpoint, it's worth a conversation and can be considered for patients who consider themselves to be at high risk. So multiple sexual partners, non-monogamy, these folks should be having conversations with their doctors about whether doxypep would be a good option for decreasing the risk of transmission of gonorrhea, chlamydia, and syphilis. The questions that typically come up around this are, what about antibiotic resistance, which Khristina touched on a moment ago? And the thought of the people who are in positions much more powerful than mine is that if you're decreasing the risk of infection by 80%, you're thereby decreasing the need for a full course of treatment dose antibiotics. So there will overall be less antibiotic resistance if we're preventing transmission. I've also heard questions about, like, is it going to affect the gut flora? Because I'm very thoughtful. If I put a patient on antibiotics, I'm probably going to wipe out their good gut flora. And there hasn't been any data to suggest that that's the case. Doxycycline can cause nausea, GI upset, diarrhea in some patients to the point where they can't take it. It also can cause photosensitivity or sensitivity to light. So if patients are taking doxycycline on a regular basis, they need to be very mindful about the time that they spend in the sun and wear sunscreen and not be in too much direct sunlight. So overall, prevention strategies for those of us who enjoy healthy sex lives: regular screening, including throat swabs and rectal swabs where indicated. Talk with your potential partners about their STI status. Ask them when their last screen was. I ask for proof, like ask to see their paperwork and be willing to show them yours. It's just that extra level of trust and, frankly, the maturity to be able to have the conversation. Don't assume monogamy unless you've specifically addressed that with your partner or patient. There's increasing data to suggest that, you know, the apps are evidence of this, right? Like, we live in a hookup culture, like people are out here enjoying themselves. And so to make the assumption of monogamy, I think is kind of a little like putting our head in the sand. Get the HPV vaccine if you consider yourself at risk and qualify for it. talk to your doctor or healthcare provider about PrEP if you're at increased risk of HIV. Talk to your doctor about DoxyPep if you're in the populations that I suggested. Barriers, condoms, Laurel's now makes they're like latex underwear for women. So when one is performing oral sex on a woman, it's like you don't have to use the dental dam, but dental dams are still out there and available. But again, things like HPV and HSV and molluscum contagiosum, these things can be spread even in the absence or even in the presence of barrier protection. Toys, if you're not sure about someone's status and you still want to play with them, whip out your toys, and you can still have a great time using hands and toys without exchanging bodily fluids or involving yourself in actual like fluid exchange. Valtrex suppression if you're on HSV, and this I feel like should go without saying, but it doesn't. Wash your hands. So if you've been out and about and you're coming home from the train station and you're getting ready to go to bed and play with somebody, like wash your hands before you start touching their genitals and like sticking your fingers in their mouth. And also wash your hands and your toys between partners if you're playing with multiple people. If you're have been involved with someone with anal play, wash your hands before you touch them elsewhere on their body. Just remember that all of those things can be transmitted through your hands too. So resources, our websites are here at the top of the screen, artemisluxurywellness.com. I'm putting good information out there and continuing to try to crank out meaningful content. drkbooth.com. She's also on TikTok. I'm on TikTok, but I don't produce content. She's much better at it than I am. Rosie is a really cool app for sex education. Bloom is an app that I use both for workshop and education and also networking. It has like dating app features, but you don't even have to turn those on. I use it like professionally to go to workshops about non-monogamy and kink and all these different types of things. OMG Yes is a great resource about sexual health and pleasure. Beducated.com again has a lot of information and workshops on kink and sexual health. Scarletine and amaze.org are great resources for parents and adolescents. They have developmentally appropriate educational resources and like how to talk with kids about human sexuality and consent in their bodies and changes. I got most of the information about my STI stuff from the CDC website, which has tons of resources on STIs. And these are our websites and socials. And we are right at the top of the hour. So
Look at
let's
that.
see if there's any questions. Feel free to put any questions in the chat.
We haven't had any.
Oh. Well, if nobody has any questions, I just want to thank you guys all again for coming here tonight and hearing what we have to say. Follow us on the socials, and I'll put a recording of this up on my website in short order.
Awesome. Thank you for having me. It was so much fun.
Yes, I learned so much from you. I always do.
You too, for sure.
All right, everyone. Have a good night. Thank you.
Thank you. Bye bye.